You are able to see the slides. So the blood and blood components, the preparation, indication and uses. That is how usually the questions are worded. They can be classified. The blood components can be classified into cellular components, which are the red cell concentrate, leukocyte reduced red cells, platelet concentrate, leukocyte reduced platelet, platelet apheresis and granulocyte apheresis. These are all the various cells that can be segregated from the blood. Then the second is the plasma component, which can be classified into fresh frozen plasma, single donor plasma, cryoprecipitate, cryopoor plasma, plasma derivatives like albumin and which are in different concentration. The third is plasma protein fractions, which are factor VIII concentrate, immunoglobulins, fibrinogen, and other coagulation factors like prothrombin concentrate, etc. Now, how do you prepare the blood? How is it possible that how are we able to use the blood component is the invention of multiple plastic pack system, refrigerated centrifuge, different specific gravity of cellular components, which are all the three things which made possible to separate the components from the whole blood. So the multiple plastic pack system, refrigerated centrifuge, different specific gravity of cellular components. For example, red cells have a specific gravity of 1.08 to 1.09. Platelets are slightly less heavy, 1.03 to 1.04, and plasma specific gravity is 1.02 to 1. So that is why earlier days when we do the ESR, erythrocyte sedimentation, right, we used to simply keep the filtrated blood in a tube and all the cellular elements will gravitate down and the supernatant plasma will separate. So that is the technique which is used basically for these methods of separation. And what are the equipments you need to do the blood component separation? You need a freezer which should be have a temperature of -40 to -70 degrees. Then there should be a blood bank refrigerator which can store the components between 2 to 6 degrees centigrade. A refrigerated centrifuge with a swing out head and oval cups. Then there should be laminar flow, weighing scale, dielectric sealer or aluminum clips for sealing, stripper, water bath or microwave for thawing, and platelet agitator and sterile docking devices. These are all the equipment that you need. Now coming to the method of preparation, you can do what is called gravity separation. This is the oldest method. Then low and high speed centrifugation and apheresis by cell separator. These are the three methods by which we do the component separation. Now, what are the precautions you have to take while you are doing this? In collection of blood, proper selection of donor, clean and aseptic site for venipuncture, uninterrupted flow of blood from the donor, collect correct amount of blood, automatic mixing of blood during collection with the uh, uh, anticoagulant, separate platelets within 6 to 8 hours. This is very important. And triple pack and quad pack system collection is very important. I will show you how they will look like. The precautions in centrifugation, balancing and use of rubber disc is very important. Broad side of the bag faces the outside wall of the cup. Correct speed and time to be maintained. Look for any abnormal vibration in the centrifuge. And preparation, first thing we use to separate is the RBCs. So packed RBCs preparation is obtained by removal of supernatant plasma from centrifuge whole blood. So the whole blood is put in a pack and then centrifuge, and the supernatant plasma can be drained from that, and the sedimented RBCs are collected in appropriate volume of donor blood in a CPDA mixture. This is the anticoagulant mixture, citrate, phosphorus, dextrose, and double or triple bag, stored at 2 to 6 degree till process. Place bags in buckets of refrigerated centrifuge and balance the opposite bag accurately, and centrifuge at a heavy spin. So for separating RBCs, you have to use what is called heavy spin. for 5 minutes at 2 to 6 degrees centigrade. Then express approximately 3/4 of the plasma into the satellite bag. So these bags will be connected to each other by communication, and that can be sealed and separated later. So double seal the tube between the satellite bags with the plasma separated, and then the temperature, keep the red cells stored at 2 to 6 degrees centigrade. Now, red cell concentrate quality indicators. What are the indicators for that is a good RCC? The volume is usually about 250 to 300 ml, and the hematocrit, examiners sometimes ask you this question: what is the hematocrit of your packed RBCs you give for the patient? It is 55 to 75%, and the hemoglobin will be more than 45 grams per deciliter because we have removed all the plasma. There is no diluent in that, and so the hemoglobin concentration is very high, and the pH is between 6.4 to 7.4, and there is a possibility of mild hemolysis occurring, which should be less than 0.8%, and it should be quite sterile, and very minimal leukocytes can be there. Residual leukocytes will be less than 2 into 109 units per vg. Then the next type of RBC is leukocyte reduced. So in packed RBCs, you have some amount of leukocytes still present in that. You cannot, you have not eliminated all or removed all those WBCs. So if you want specifically, you can use what is called leukocyte reduced RBCs. For preparing that, you do the centrifugation and removing the buffy coat on the top. Then you have to do filtration, then wash the red cells with saline, and freezing and thawing of the red cells is done. So if you get a leukocyte reduced RBCs, it is much more frozen, and so it needs thawing before you use, which you are not going to use like the regular PRBCs which you are using. Next comes the platelet concentrate preparation. You can do a random donor platelet prepared from 450 ml of whole blood, and if you take it from a single person, it is called single donor platelet prepared by apheresis. And the procedure for that is collect in a triple pack system stored at a room temperature 22 to 26 for less than 6 hours. So as I told earlier, platelet, if you want to separate, it should be done within the first 6 hours of collection. Place the bags in buckets of refrigerated centrifuge and balance the opposite bags, and express about 4/5 of the platelet-rich plasma in the satellite bag. Then centrifuge the bag with platelet-rich plasma and another satellite bag at 20 to 40 degrees at 5 to 5,000 revolutions per 5 minutes. Express supernatant platelet poor plasma into another bag. So first you separate the platelet rich plasma, then you centrifuge that again and remove the plasma to make it platelet rich plasma, and then transfer the platelets at store them at 22 to 22 degrees under constant agitation. So what are the precautions you have to do? Agitation during storage helps to prevent the exchange of gases, maintenance of pH, reduce formation of platelet blood, and pH should never fall, and change in the shape of the platelets can happen. Pseudopore formation can happen, and release of platelet granules. So the quality of action of platelets will be lost if this is not taken care of. And what are the quality indicators for the platelet concentrate? The volume is about 45 to 55 ml only, and swelling is present. Platelet count is more than 55 into 100.9 units. Residual leukocytes, there may be some amount of white blood cells present, and some very small amount of red cell also may be present, which is should be less than 1 into 109 units. And pH is same like your PRBCs or RCC, 6.4 to 7.4, and it should be quite sterile. So these are all the quality indicators. And the next thing is preparation of fresh frozen plasma. Again, you collect the whole blood in triple pack system. Then after centrifugation at 4 degree, and place the bag in buckets. The same procedure as the thing, and then express 4/5 of the plasma in the satellite bag. Then label the plasma and rapidly freeze it within. So fresh frozen plasma, the immediate step after separation of plasma is to freeze the plasma within 6 to 8 hours, and freezing process should not be more than 1 hour at minus 70 degrees. And this can be stored at minus 30 degrees or below for up to 1 year. So FFP can be stored for up to 1 year, and thaw it in plasma defroster or microwave, place it in plastic overwrap and put it at 37 degrees circulating water bath. These are all the methods of thawing the stored fresh frozen plasma. The precautions you have to take is, again, flow should be continuous, no interruption. 450 bags should be not take more than that. During the procedure, freezing of the plasma as soon as possible and maintaining the storage temperature. During thawing, the entire pores of the bag should remain above the water level. No water should enter inside if you are doing it in the water bath. And you should administer within 12 hours if you are going to keep it at 2 to 6 degrees centigrade. And the quality indicators for fresh frozen plasma are, the volume of FFP is usually 180 to 200 ml. So because of this larger volume, they were using this as a volume replacement, which is not now recommended at all. And factor 8 levels should be more than 0.7 international units. Fibrinogen level should be more than 300. So you get these two important components in the FFP. One is factor 8, another is fibrinogen, and it should be sterile. And the frozen plasma can be thawed at 1 to 6 degree, centrifuge and plasma express, leaving behind a precipitate known as cryoprecipitate or cryo, which can be both stored subsequently at minus 18 degree. So the fresh frozen plasma that is thawed is centrifuged again, and the plasma express, leaving behind the precipitate. So that is how the cryoprecipitate is produced. And what are the indications for use of FFP, which is a very common thing used nowadays? Indicated if deficiency of coagulation factors, especially factor 8 and fibrinogen are there in abnormal coagulation tests, which are found out by the bedside. Nowadays we have thromboelastography, which will be able to tell you what is the factor that is deficient. And FFP is also indicated for planned surgery or invasive procedure in the presence of abnormal coagulation, and for the reversal of warfarin in the presence of active bleeding. For example, a patient who is on warfarin, if you want to take him up for an emergency, there is no time to stop the drug and then to take up the patient. You should always have FFP ready. Or for a planned procedure where vitamin K reversal is not adequately working, or in thrombotic thrombocytopenic purpura and congenital or acquired factor deficiency with no alternative therapy, and trauma patient requiring massive transfusion. Those patients also, the usual guidance is 1:1:1. That is how you just give. So to prevent the dilution with all the other infusions that you give, FFP is indicated. And warfarin related intracranial hemorrhage, in that condition also you can use FFP. And conditions that cause deficiency of multiple coagulation factors may require administration of FFP, like liver disease or disseminated intravascular coagulation. And FFP must be ABO compatible with recipient red cells. This is very important. What are the contraindications for usage of FFP? Contraindicated when coagulopathy can be corrected more effectively with a specific therapy. Contraindicated when blood volume can be adequately replaced with other volume expanders. This is the point I have been telling you again and again. And FFP is contraindicated for reversal of anticoagulation induced by heparin or direct thrombin inhibitors or direct factor 10A inhibitors. So nowadays patients who are on anticoagulant drugs, I think that is going to be the question for the next class, anticoagulants and anesthesia. So some patients may be who are earlier cases of PVT or pulmonary embolism, or patients who are on coronary stents, they may be on anticoagulant drugs. So FFP is not the drug of choice for reversing the anticoagulation effect of these drugs. There are specific anticoagulants, the reversal agents. Heparin, of course, you have protamine, and other drugs also you have the drugs to prevent the anticoagulation effect. So diagrammatic representation, this is what happens. This is what I told you. This is called the satellite bags. So whole blood with satellite bags. You can see first the whole blood is collected in this, and this bag will be centrifuged, and then from there you can platelet rich plasma is expressed into the next bag, and then from this, if you want platelet poor plasma, you again centrifuge and then separate the platelet, and then leave the platelet poor plasma here and then make it a platelet. So this is called the satellite bag. So like that you can go on be doing that, and once you separate the plasma here, it becomes RBC concentrate, packed red blood cells. So you can just seal the bag here and remove this. Like that you can remove the second bag, which will become platelet concentrate, and then you can freeze it and it becomes fresh frozen plasma, and then fresh frozen plasma you thaw it and centrifuge, then you get a cryoprecipitate. So these are the four major components you have to remember: packed red blood cells, platelets, FFP, cryo. Okay, this is the method by which it is being done. These are all the centrifuges that are being activated and done. Now, one word about apheresis. What is the actually apheresis is? The blood is taken like this. So the blood is collected, components are separated. The target finished factors will be components like platelets, red cells for transfusion, and plasma for pharmaceutical manufacturing. Then whatever is left behind is returned to the patient. So that is the difference between the simple collection and component separation. In apheresis, the donor donates the whole blood. You separate whatever components you want, and return back the leftovers back to the patient so that it doesn't become volume depleted. Okay, so these are the things that you have to remember in blood components.